and clear.
Okay. All right. Okay. So next. All right. So my first topic will be regarding the epidemiology of heart failure, and I will be presenting more about the various type causes, pathophysiology of the heart failure. So next. So regarding the epidemiology, so this is taken by the CPG Management of Heart Failure 2019. The prevalence of heart failure varies between 3 to 20 per 1,000 population. Although in person over the age of 65 years, it could be as high as 100 per 1,000 population. In nearly all regions of the world, heart failure is both common and increasing, affecting between 1 to 2% of the population. So as we can see from this uh, diagram from the Department of Statistics Malaysia. One of the causes of death of Malaysia is ischemic heart disease, and ischemic heart disease is one of the main cause of heart failure among adult Malaysia. So we can see the ischemic heart disease compulsory about 15% of the causes of death in 2019. So it's an increasing and common phenomenon affecting the population. So next. So what is heart failure? So this is taken from the textbook Command Clinical Medicine and also CPG Management of Heart Failure. So the definition for Command Clark is stated as heart failure is a complex syndrome that can result from any structural or functional cardiac disorder that impair the ability of the heart to function as a pump to support a physiological circulation. And from CPG, heart failure is a clinical syndrome due to any structural or physiological abnormality of the heart, resulting in its ability to meet the metabolic demand of the body. So, to further explain it, so heart failure occurs when there is more oxygen demand than oxygen supply due to functional or structural cardiac disorder that impairs the ability of the heart to meet the oxygen demand. So that's for this definition of heart failure. Next. Okay, so causes. So we have talked about the structural and functional cardiac impairment of the heart that can cause heart failure. So one of the main causes taken from Kumar and Clark Clinical Medicine is IHD, 35 to 40%, dilated cardiomyopathy, 30 to 34%, and hypertension, 15 to 20%. So these are other causes that is also
The clock.
huh?
Continue. Sorry.
Okay.
Continue.
Also stated by the
Orang tengah
Command Club
cakap dengan
Clinical
orang lain ke?
Medicine. So
Lepas tu
as
cakap
I explained before, when there
yes,
is
didn't do anything for
inability
me
to meet
before.
oxygen demand, uh,
Betul tu.
there will be a cause of heart failure. So the inability to meet the oxygen demand is due from impact cardiac function or due to excess work demand. So impact cardiac function such as any incidence of myocardial disease such as cardiomyopathy, myocarditis, coronary insufficiency or MI, any valvular heart disease or also congestive pancreatitis. So this can impair cardiac function and affect the ability of the heart to deliver oxygen. And excess work demand, increase in oxygen demand due to increased pressure work, increased volume work, or increased precision work, as stated here. Okay, so next. So we already know the epidemiology, the definition, and the causes of heart failure. So I will be explaining regarding a bit for pathophysiology of heart failure. The failure of the heart involves interaction between two factors: a decrease in cardiac output, which decreases blood flow to organ, thus reducing organ perfusion, and this is compensated by the recruitment of this mechanism designed to maintain the cardiac output and the tissue perfusion. But as heart failure progresses, these mechanisms are overwhelmed and become pathological. Okay, so the compensated mechanism is the Frank-Starling mechanism, myocardial hypertrophy, increasing the sympathetic activity, rush mechanism, and changes in arterial function, which I will explain a little bit more in the next slide. These are the pathology of changes that occurs within the heart, uh, which is by ventricular dilation, myocyte hypertrophy, and all of this, all to increase the cardiac output and to meet the body demand and to increase the oxygen delivery. So next, so regarding the first compensatory mechanism is by increasing sympathetic activity. So the sympathetic activity is activated via baroreceptor as an early compensatory mechanism. It provides inotropic support and maintain the cardiac output. Chronic sympathetic activation, however, has deleterious effect by further increasing the neurohormonal activation, the RAS system, and also the myocyte apoptosis. So this is compensated by downregulation of the B receptor or baroreceptor. So that's for increased sympathetic activity. Next. Also, there will be a myocardial hypertrophy.
Insect.
Myocardial hypertrophy can be
Apa?
divided to
Gerakkan
concentric
gerakkan si
hypertrophy or
insect tu.
eccentric hypertrophy. So the aim of myocardial hypertrophy is to also to increase the cardiac output, whether to increase the end-diastolic volume, increasing the venous pressure, or to increase the stroke volume, to increase the volume of the heart, volume of the blood ejected in each heartbeat. So that is two concentric hypertrophy. The thickness increase, but the diameter not dilated, and eccentric hypertrophy, where the thickness decrease and the diameter dilated. Okay, so next. Next is the activation of the renin, angiotensin, aldosterone system. So activation of the RAS system is due to several factors such as decreased perfusion to the kidney, reduction in the renal tubular concentration of sodium, and increasing activity of the sympathetic nervous system. This is a bit about the RAS system. So renin is produced by the kidney, and renin will convert angiotensin, which is produced by the liver, to angiotensin 1. Angiotensin 1 will convert to angiotensin 2 at the lungs by the angiotensin converting enzyme, and angiotensin 2 will affect the water and salt retention, thus increasing the venous pressure, and increasing the endosteric volume, increasing the stroke volume and cardiac output.
Oh, stroke volume.
That's for the rest system
Nak
mechanism.
telur
So
dengar.
next, okay, for another compensatory mechanism is the front standing mechanism. According to the front standing mechanism, left ventricle is able to increase its force of contraction and therefore stroke volume in response to increase in venous return and hence payload. So in an intact heart, this phenomenon is described as increase of stroke volume with an enlargement of the diastolic volume. We can see the graphs, ventricular performance to the venous pressure filling. So when there is a increase in venous pressure, there will be increase in ventricular performance. So when there is increase in the ventricular performance, more blood will be ejected in within each heartbeat. Next. And the last thing is the changes in endothelial function. So endothelium has a central role in regulation of the vasomotor tone. In patients with heart failure, endothelium-dependent vasodilation in peripheral blood vessel is impaired and may be one of the mechanisms of exercise limitation in this patient. So why that did impact? It regards to the abnormal release of nucleic acid and vasoconstrictor substance such as like endothelin. So action of the nitric oxide, a potent vasodilator in heart failure, is blunted, and endothelin secretion in heart failure from variety of tissue is stimulated by many factors such as hypoxia, um,
Catecholamine.
secretion of catecholamine, and activation of RAS by angiotensin 2. Okay, so next. Right, so that's regarding the um, compensatory mechanism in heart failure. Next is acute versus chronic heart failure. So acute heart failure is a rapid onset of sign and symptom of heart failure due to an acute deterioration of cardiac function. in the presence or absence of previous cardiac disease. So this is a mnemonic which we can also remember, um, which is the heart failure, hypertensive crisis, electrolyte imbalance, ACS, restriction of fluid not followed, thyrotoxicosis, fluid retention due to NSAID, arrhythmia, infection, low hemoglobin, and stress. These are all the factors that can contribute to acute deterioration of heart failure. So for chronic heart failure, it is usually a stable symptom and develop compensatory mechanism like tachycardia, cardiac hypertrophy, all to maintain the cardiac output. So it may be due to MI, valvular heart disease, systemic hypertension, and chronic lung disease. Okay, so that's for acute to chronic heart failure. So next, so next another classification of the heart failure is systolic and diastolic heart failure. So when there is systolic dysfunction, um, there will be so for systolic heart failure, the heart can will not be able to pump out the blood in each heartbeat. So there will be an increase in end diastolic volume and a decrease in stroke volume. So ejection fraction usually is reduced in the systolic heart failure. For diastolic heart failure, there is increased stiffness in the ventricular wall, leading to impairment of diastolic ventricular filling. So there will be a decrease in end diastolic volume, but there's an decrease in the stroke volume as well because of the total end diastolic volume. But when we calculate the ejection fraction, stroke volume divided by end diastolic volume, they will usually be preserved in the early diastolic dysfunction, but they can also be reduced because diastolic dysfunction also lead to systolic dysfunction. Okay. Diastolic heart failure is more common in elderly hypertensive patients, but may occur with primary cardiomyopathies such as hypertrophic, restrictive, and insensitive. Alright, so most of the cases are mid systolic and diastolic. So next is regarding the clinical feature of heart failure. So right heart failure is more to the back due to buildup of blood into the systemic circulation. There will be a congestion of peripheral tissue, and there will be a clinical manifestation. Usually due to because of this, there will be a clinical manifestations such as edema, ascites, GI tract congestion, and also liver congestion. But for heart failure, it is usually due to backup to the pulmonary congestion, which can cause impaired gas exchange, hypoxia, and also pulmonary edema, development of atomia, PND, and causes of disease. So next, so this is the clinical feature like I mentioned before this. So general feature is chest pain, palpitation, fatigue, ST and S4 lipidem and cardiomegaly, and left-sided heart failure more to the pulmonary circulation that back up to the congestion of the pulmonary circulation, dyspneic, autopneic, PND, basilar precipitation, and for cardiac asthma. And right-sided heart failure is due to congestion to the systemic circulation, which can cause manifestation of edema, anorexia or weight loss due to GI tract infection, anasalca, arthritis, hepatosplenomegaly due to liver congestion. So that's for clinical feature. Next, another important features of heart failure that we need to distinguish in this patient is classification of New York Heart Association, which identify the limitation of the physical activity of the patient. So we need to identify in patient with heart failure. So class 1, there will be no limitation of physical activity. Class 2 is slight limitation of physical activity, but the patient is still comfortable at rest. Class 3, there is a marked limitation of physical activity. And class 4 is severe, unable to carry out any physical activity. So this is also a clinical feature of heart failure that we also need to identify in patient. Alright, okay, so that's all for me. Next is Noah. Any question?
Ada 30 minit. Oh no, sir.
Yeah, Noah.
So question, okay, continue. Okay. So I'll be talking about different investigations that we can conduct with regards to identifying heart failure. Next slide, please. So first and foremost, the American College of Cardiology, American Heart Association, as well as the Heart Failure Society of America guidelines recommend the following diagnosis for heart failure. We are advised to get a 12-lead ECG, chest X-ray, transthoracic echocardiography, or you can also perform a transesophageal echocardiography if the patient is on mechanical ventilation or morbidly obese, as well as for those who the TTE is optimal for imaging. At the same time, we can get readings such as the BNP and your basic FVC views, fasting lipid profile, HbA1c, thyroid function test, and iron studies. So next slide. So with regards to the 12-lead ECG, the presence of left atrial enlargement and left ventricular hypertrophy is sensitive but not specific to chronic left ventricular dysfunction. However, if the ECG of the patient presents as a normal ECG, then it's very unlikely that the patient is having heart failure. So we'd want to look at other differentials. ECG may suggest acute tachyarrhythmia or bradyarrhythmia as the cause of heart failure, and it may also aid in the diagnosis of myocardial ischemia, infarction, prior MI, or the presence of coronary artery disease as a causative factor for the heart failure. All right, next slide. So what we expect to see on an ECG is number one, the evidence of right ventricular hypertrophy in the case of right side heart failure. So for that, we expect to see right axis deviation, a dominant R wave in V1, as well as a dominant S wave in leads V5 and V6. We can also look for evidence of right atrial enlargement, which presents as a peak P wave, otherwise known as P pulmonale, which is more than 2.5 millimeters in the inferior leads and more than 1.5 millimeters in the anteroseptal lead. For the left side heart failure, we can look for evidence of left ventricular hypertrophy, which is left axis deviation, and we can also use the Sokolov-Lyon criteria. So for this particular criteria, you would take the S wave depth in V1 as well as the tallest R wave height in V5 V5 or V6, and you add those two together, and if it's more than 33 millimeters, then it's positive. You can also look for ST depression and T inversions that correspond to left ventricular strain. Also, for evidence of the left atrial enlargement, we're looking for a broad bifid P wave in leads 2, otherwise known as P mitrale, and an enlarged terminal portion of negative P wave in V1. So the picture that I've attached on the upper left corner shows the different P wave morphologies for different atrial enlargements, right and left. Next slide, please. So these two are examples of ECG strips of patients in both right and left ventricular heart failure. So on the left side, you can see this patient has right axis deviation, dominant R wave in V1, dominant S wave in V6, as well as ST depression and T inversion in leads V1 up to V4, which corresponds to right ventricular strain. So this patient can be said to be suffering from right ventricular failure, right-sided heart failure. On the right hand side, this patient has left axis deviation, and as you can see, the S in V2 and the R in V6 sums up to be much more than 33 millimeters. So that corresponds to the criteria that I mentioned in the previous slide, as well as you can see ST depression and T inversion in leads 1, AVL, V5, and V6, which corresponds to left ventricular strain. So this patient has left-sided heart failure. Okay, next slide. So with regards to a chest X-ray, the easiest way to the criteria to look for with regards to heart failure in a chest X-ray can be divided into this mnemonic, which is A, B, C, D, E. So what we're looking for is alveolar edema, curly B lines, cardiomegaly, as well as dilated upper lobe vessels and pleural effusion. So these are two pictures of patients with heart failure, and both of them, as you can see, have cardiomegaly as well as small pleural effusion with the evidence of loss of the phosphorentic angles on the patient on the left, and pulmonary congestion for the patient on the right. Okay, next slide, please. All right, next we'll be talking about the transthoracic echocardiogram. So basically, what we have to know is this particular study is for us to be able to assess left ventricular chamber size as well as volume and systolic function, which is seen as the ejection fraction. You can also look for left ventricular wall thickness, evidence of scarring and wall motion abnormalities, diastolic function of the heart, and we can have a look at the valvular structures and the function, as well as congenital cardiac abnormalities and left ventricular mechanical dysynchrony and pulmonary hypertension. So this is an example, the image is an example of what you would expect to see on a transthoracic echocardiogram. So this is a 2D echo showing a 4-chamber view of the heart. And it's worth noting that this patient has a very, very prominent left ventricular dilatation. It's also noteworthy to point out that ejection fraction of 40 and below is considered a reduced ejection fraction, and 50 and above is a preserved ejection fraction, with 41 and up to 49 is mid-range. Next slide. All right, next we can look for BNP and ANP, which is basically these are the hormones that are produced by the atrium and the ventricle with regards to straining of the cardiomyocytes. So just to recap, as what I think Shazwan already explained, when there's the presence of cardiac strain, uh, as evidenced by cardiac distension, sympathetic stimulation, and release of angiotensin 2, we get an increase in the ANP and BNP. And what these two hormones do is they vasodilate as well as reduce the RAS system, which overall would reduce blood volume and decrease blood pressure. So the optimal cutoff points for diagnosis or exclusion of heart failure among patients that present with dyspnea, as you can see, if the BNP is less than 100 nanograms per liter, then we can safely rule out heart failure if that's the only finding. Of course, you have to correlate with other investigative findings as well. Heart failure is possible if the BNP is more than 400. And anti-pro-BNP is basically just the pro-hormone for BNP, which gets cleaved and becomes BNP. So we can have a look at that as well. I think that's it for me. Next slide. All right, yeah, so pass it to Nurul Azmi. Thank you very much.
Thank you very much.
Okay, thank you. So next I will talk about evidence-based medicine about ACE inhibitor and ARB, angiotensin receptor blocker.
EBM.
So I think Shazwan has touched on this, but just want to recap that ACE inhibitor will block angiotensin converting enzyme at the blood vessel or adrenal gland, while ARB will block angiotensin at the angiotensin receptor. This will cause vasodilation and also prevent production of aldosterone, which will reduce the reabsorption of sodium and water. Next. So we look at the CPG of heart failure first. This is in 2019. So for the grade of recommendation, the best one is grade 1, while levels of evidence, the best one is A, which data is derived from multiple randomized clinical trial or
Dia dah
meta-analysis.
buff Gushin, so dia kena buat skin Gushin untuk milk the fuck out of it.
So from this CPG, uh, for evidence 1A, as inhibitor improve survival and quality of life in all classes of heart failure. So this first line of drug should be given to all heart failure with reduced ejection fraction patients. And angiotensin receptor blocker also is indicated in heart failure with reduced ejection fraction in ACE inhibitor intolerant patient. This is because as inhibitor, the side effect is cough lah, dry cough. Okay. So ARB are also indicated in heart failure with reduced ejection fraction However, there is no difference between both drugs in terms of cardiovascular outcome, such as mortality and heart failure hospitalization. In patients with post-myocardial infarction with impaired left ventricular function, valsartan, which is an ARB, was found to be as effective as captopril. So for those patients who is intolerant for with captopril, we can use valsartan. And lastly, routine combined use of both ACE inhibitor and ARB should be avoided as this will cause more adverse effect like hypotension, hyperkalemia, and renal dysfunction. So this is the EBM levels of evidence pyramid. Most of the clinical trials that I will be presenting next is more on meta-analysis, the highest order of EBM level, and also randomized control trial. Next. So in a study done in 1995, what to study the role of S inhibitor in heart failure, the aim is to evaluate the effect of angiotensin converting enzyme inhibitor on mortality and morbidity in patient with congestive heart failure. This is a randomized control trial study, and patient with uh, class 2 and class 3 according to New York Heart Association was chosen with ejection fraction ranging from 0.35 to less than 0.5. Okay. So the intervention done was ACE inhibitor compared with placebo was used for at least 8 weeks. Next. So from this study, the result was in ACE inhibitor group, the death was the result of death was 15.8%, while in control group is 21.9%. Just want to recap for you. Control group means group that does not receive the new treatment or treatment given to the patient. So control group will receive placebo, while ACE inhibitor group will receive the ACE inhibitor lah. Okay. So overall, those who died or hospitalized for congestive heart failure on ST treatment, ACE inhibitor is 22.4%, while placebo is 32.6%. Okay, so the conclusion is total mortality and hospitalization for congestive heart failure are significantly reduced by ACE inhibitor. Uh, okay, next. So this is another study done in 2008 to assess the effect of angiotensin converting enzyme in patients with left ventricular dysfunction or heart failure. This is also a randomized control trial. Okay, next. And the study also gave the same result, which most mortality was significantly lower with ACE inhibitor compared to placebo. Okay, next. So you might ask, how about angiotensin receptor blocker in heart failure? So a study in 2004 was done, a randomized control trial, which the aim is to determine the efficacy of ARB in patients with chronic heart failure and high risk of acute myocardial infarction. Okay, next. So the result was ARB were associated with significant reduction in both all-cause mortality and heart failure hospitalization. So there is no significant difference found between combination of ARB and ACE inhibitor and ACE inhibitor alone for all cause mortality. So
Okay.
like I said before, the CPG told us that ACE inhibitor and ARB should not be combined for their usage. So this study just want to prove that if you want to use ARB alone, is okay because there's no difference. Next.
Faham? Recash.
So, how about if ACE inhibitor replaced by ARB? If a patient was given ACE inhibitor before, we replace with ARB. What is the outcome? Is it better or not? So, a study was done on 2008 where randomized control trial was done on patients that is intolerant to ACE inhibitor. Uh, okay, so uh, next. So, from this study, the mean blood pressure was lower in telmisartan group. Telmisartan is ARB than in the placebo group throughout the study. And then 15.7% patient experienced the primary outcome in telmisartan group compared with 17% in placebo group. Secondary outcome like cardiovascular death, myocardial infarction, or stroke occur in 13% of the patient with telmisartan, and also 14.8% on the placebo. So in conclusion, telmisartan was well tolerated in patient that is unable to tolerate ACE inhibitor. However, just like the CPG said, there is no difference in outcome of the drug, especially in the cardiovascular outcome. Okay, next. So, which is better, uh, alone or both? Okay. So, a study was done in 2004 to compare the effect of ACE inhibitor, captopril, and also ARB valsartan. This is a double-blind trial. Double-blind trial is where the participant and the researcher don't know which treatment this patient receive to avoid a bias lah. Okay. So next. So in 979 patients in the valsartan group died as 941 patients in valsartan and
Tiba-tiba
captopril
Valsartan
group,
group died.
and also
Terkejut je.
958 patients
Valsartan
in
group died.
captopril group alone. Okay, so from this, valsartan is as effective as captopril in patients who are at high risk for cardiovascular event after myocardial infarction, and also combining both valsartan and captopril increase the rate of adverse event without improving survival. Another study was done in 2012 to assess the benefit and harm of ARB compared with ACE inhibitor or placebo on cardiovascular outcome. Next. So in ARB versus placebo group, two of the included study reported total hospitalization uh, for heart failure. Reduction in hospitalization for heart failure with ARB was of borderline statistical significance at the 5% error level. You can read all of this later, but the conclusion for this study is there is no difference between the two drug classes in total mortality, cardiovascular mortality, stroke, myocardial infarction, or even total hospitalization for heart failure. Next. So how about the side effects? As we all know, as inhibitor, usually patient will complain of dry cough. However, there are some occasion where ARB patient will have angioedema. Angioedema is where your face, your pharynx, your tongue and lips all will be swollen, and this will cause what we call difficulty in breathing lah. Okay. So a study was done in 2008 to assess the risk of angioedema in ARB in patient with prior angioedema with angiotensin converting enzyme inhibitor. Next. So from the conclusion of this study, there was limited evidence to suggest that angiotensin receptor blocker could be administered to a patient who had previously experienced angiotensin converting enzyme inhibitor induced angioedema. This is because patient rarely come with angioedema. However, it is there. Okay. But patient also should be suitably as advised lah, of the risk of recurrent angioedema. Next. So how about the efficacy of the drug? So a study was done on
Oh, kenapa gugup?
2016 to evaluate the efficacy and safety of different ACE inhibitor in patients with chronic heart failure. Okay, next. So from this result, we can see that uh, enalapril is good in to improve stroke volume, ejection fraction, and also mean arterial pressure. However, it comes with the worst outcome of deterioration of renal function, gastrointestinal discomfort, and
Oh.
also
It's good
mortality lah.
for your blood
Okay.
pressure but
And
very
also
bad to your
for trendolapril,
faham?
it is good for controlling the systolic and diastolic blood pressure. I think that's all for my presentation.
Faham? Very good. Ingat Zul, the
Okay,
medication yang
Assalamualaikum
booster
Prof
you
and fellow group mates. My name is Afifa and I'll be presenting regarding evidence-based medicine on role of beta blockers in heart failure. Okay. So these are the classes of beta blockers. So we can divide it to cardioselective, non-cardioselective, and also mixed alpha beta blockers. So for beta blockers that act on for cardioselective beta blockers, they act mainly on the heart and also on the kidney, which subsequently can increase the heart rate, increase the contractility, and also uh, reduce will reduce the heart rate, reduce the contractility, and also reduce the renin release. So some example of the cardioselective beta blockers include atenolol, metoprolol, bisoprolol, and also nebivolol. So for nebivolol, it is different from the rest because it is a third generation beta blockers, whereas the rest of cardioselective beta blockers are from the second generation. Okay, next is the non-cardioselective, which bind to the beta-1 and also beta-2 receptor, which mainly act on the vascular or bronchial smooth muscle. And then for mid alpha beta blocker non-selective, it binds to beta-1, beta-2, and also to alpha-1 receptor. For example, labetalol and also carvedilol. Okay. Okay, so these are based on CPG treatment of heart failure. These are the recommended beta blockers and dosage used in heart failure. We have bisoprolol, carvedilol, metoprolol succinate, extended release tablets, and also nebivolol. So each of these beta blockers and their initial and target dose actually has been proved its efficacy via some clinical trials that we're going to look after this. Yeah. So this table shows the summary of randomized clinical trials in heart failure with a reduced ejection fraction. So next slides will be discussing on the summary of study of merit HF, study regarding metoprolol versus placebo. CIBIS2, which is a study comparing between bisoprolol and placebo. And then we have Copernicus and also Seniors for carvedilol and also nebivolol respectively.
Tolol, tolol.
Okay, okay. First, for metoprolol study, which is the merit HF trial study. They enroll about 3,991 patients with chronic heart failure aged between 40 to 80 years old in NYHA functional class 2 to 4 with ejection fraction of 40% or less and stabilized with optimum standard therapy. They do this study in a double-blind randomized control study. And the patients were assigned treatment with metoprolol or placebo, and the starting dose for metoprolol was 12.5 milligram for NYHA 3 to 4 and half dose for NYHA 2. Okay, and then the dose will be increased to the recommended guideline up to the target dose 200 milligram once daily. Okay, so for the result of the study, okay, all-cause mortality was lower in the metoprolol group than in the placebo group. And then there were also fewer sudden death in the metoprolol group compared to placebo group, and also fewer significant reduction in death from cases of worsening heart failure in metoprolol group compared to placebo group. Okay. Okay, next is bisoprolol study, which is the CIBIS2 study that compared the bisoprolol against placebo. Whereby they enroll 2,647 symptomatic patients aged between 18 to 80 years old in NYHA class 3 or 4 with left ventricular ejection fraction of 35% or less, whereby they also receive concurrent standard therapy with diuretics and ACE inhibitors. And then they receive bisoprolol treatment, 1.25 milligram. And then the drug will be increased successfully to 2.5 and then 3.05, 3.75 and then to 5 milligram, 7.5 milligram and then to 10 milligram per day according to patient's tolerance. Okay, and the primary endpoint was all-cause mortality. Secondary were all-cause hospital admissions, cardiovascular mortality, cardiovascular hospital admission, a composite endpoint, and also a permanent premature treatment withdrawal. Okay, and the result of the study shows that there were significantly fewer cardiovascular death among patients on bisoprolol compared to patients on placebo. and also significantly fewer patients on bisoprolol were admitted to hospital for all causes compared to patients on placebo, as well as there are fewer cardiovascular deaths among patients on bisoprolol compared to on placebo. And also there are fewer combined endpoint of cardiovascular death and also admission to hospital for cardiovascular event in patient on bisoprolol compared to patient on placebo. Okay, as we can see, the figure on the bottom right, they also did a subgroup analysis by causes of heart failure and severity of the disease. However, the mortality and admission to the hospital did not differ significantly between the groups. Okay, next is the study for carvedilol against placebo, whereby they evaluated 2,289 patients who had symptoms of heart failure at rest or on minimal exertion, who had an ejection fraction of less than 25% in a double-blind trial, and they randomly assigned the patients to placebo and also on treatment for mean period of 10.4 months, and subsequently they also received standard therapy diuretic and also ACE inhibitor or ARB. And then the primary endpoint is death from any cause. Okay. Okay, the result shows significant reduction in all-cause mortality in carvedilol group compared to the placebo group. And also there's also a significant reduction in combined endpoint of death or hospitalization for any reason in carvedilol group. Carvedilol group also has permanent discontinuation of treatment 20% lower compared to the placebo group. So meaning that the treatment with carvedilol group was actually very well tolerated, evidenced by fewer patients in the carvedilol group than in the placebo group required permanent discontinuation of treatment because of adverse effects or for other reasons. Okay. Okay, sir, about this study, the advantage of this trial is that the patient in this study has more advanced heart failure compared to the patients enrolled in earlier large-scale trials of beta blockers. As we can see, they picked the candidate with the symptoms of heart failure at rest or on minimal exertion. So the patients in this study is actually on more advanced stage of the heart failure disease. Okay. Okay, next is nebivolol. Uh, uh, so this study enrolled about 2,128 patients, which age more than 70 years old with symptoms of heart failure at rest or on minimal exertion, and left ventricular ejection fraction 35% or less, receiving standard therapy, diuretic, and ACE inhibitor or ARB. Okay, and the primary endpoint was composite of all-cause mortality or cardiovascular hospital admission. Okay. Okay, so the result shows that the primary endpoint of all-cause mortality or hospitalization for coronary events was significantly lower in the nebivolol group compared with placebo, and the secondary endpoint of all-cause mortality trended lower in the nebivolol group. However, it did not reach the statistical significance. And then the primary endpoint also, as we can see in the table here, in the graph here, the primary endpoint also favored nebivolol in the pre-specified subgroups, including a patient with left ventricular ejection fraction more than 35% and also age more than 75 years. Okay, so conclusion based on these 4 studies. First, beta blockers are one of the 4 disease-modifying drugs, which are the so-called the fantastic 4 of drug for reduced ejection fraction heart failure, that have the greatest impact on the long-term prognosis of patients with heart failure with reduced ejection fraction. Okay, second, beta blockers can reduce morbidity and mortality in patients with NYHA class 2 to 4 of both ischemic and non-ischemic etiology on top of standard therapy diuretic ACE inhibitor or ARB. And then all patients with impaired ejection fraction or history of heart failure admission should be considered for beta blockers with careful titration and also monitoring, especially in patient in NYHA 3 to 4, which require close monitoring. And in our based on the guideline, the patients who come with acute heart failure who decompensate should be maintained on the same dose of the beta blockers unless the patient develop side effect, for example, hypertension or significant bradycardia, then the dosage can be reduced. And then when patient gets stabilized, then we should make an attempt to up titrate the target or maximum tolerated dose of beta blockers accordingly. And then last but not least is nebivolol is the only agent with specific evidence in the elderly and can be applied to a broad range of patients, including preserved ejection fraction. So the difference between nebivolol and other previous studies is that earlier studies usually shown benefit of beta blocker therapy over placebo in patients with heart failure, average age 61 years old. However, in nebivolol study, the average age is more than 76 years old. So nebivolol study actually show that it is recommended lah to be used in heart failure, elderly patient in heart failure, especially with those with uh, reduced ejection fraction. That's all from us. Thank you.
Okay, very good. So, any questions from the floor? I think the presentations are very clear. All right. So, I think all of you now should know how to recognize heart failure, how to make diagnosis based on the symptoms as well as signs, and also the specific investigations that you all have mentioned. All right. And the choice of its inhibitors as well as beta blockers are well spelled out. Yeah, but of course there are other medications for heart failure. Right? In this seminar, we just focus on its inhibitors, ARBs, as well as beta blockers. All right, so there are other medications that we have to use in patients who have heart failure. All right, any questions from your friends? Any questions? Speakers, do you want to add anything before we close the session? Iman, Ulul Azmi, Shazwan, Afifah, any other additional informations that you want to impart to your colleague?
I think we're okay, Prof.
No, that's
Okay.
no
No.
problem.
Nothing. All right. Then we close the session dengan
Okay.
wal asri ya. Okay. Okay. Assalamualaikum.
Salam.
Thank
Thank
you.
you
Bro.
all.